Hello everyone, and welcome back to This Week in Pulmonary and Critical Care Medicine. I'm your host, Aladdin Sagar, and every week I'll walk you through key new studies and review articles that matter at the bedside. The goal is simple. Make sure you don't miss the evidence that can influence your decisions in the ICU, the bronchoscopy suite, or the clinic. Today we'll cover several impactful studies. Real-world safety data on immunosuppressants and TNF inhibitors in sarcoidosis, new data on pneumothorax risk after endobronchial valve therapy, a major randomized trial on morphine for chronic breathlessness, and we'll close with a physiology-heavy review on where fluid actually goes during volume resuscitation. A quick reminder, the information discussed here is for educational purposes only, and not a substitute for professional medical judgment. Let's get started. Our first study, published in Chest, takes a deep dive into the real-world safety of second and third-line agents in sarcoidosis. This large retrospective cohort leveraged the TriNet-X research network, including data from 82 healthcare systems across the U.S. spanning 2012 to 2023. In total, 13,814 patients on immunosuppressive agents and 3,964 on TNF inhibitors were analyzed. Propensity score matching balanced baseline factors like age, comorbidities, and glucocorticoid use. The key comparator here is methotrexate, the workhorse of second-line therapy. Among immunosuppressants, 57% received methotrexate, 25% mycophenolate mofetil, 15% azathioprine, and a smaller number leflunomide. Results were striking. Patients on mycophenolate had a hazard ratio of 2.74 for inpatient hospitalization, 2.37 for critical care, and 4.04 for mechanical ventilation compared to those on methotrexate. Mortality risk was also significantly higher, with a hazard ratio of 2.16. Infectious complications drove much of this excess risk, particularly pneumonia and opportunistic infections. Azathioprine was associated with increased mortality, hematologic toxicity, and infections as well, though the magnitude was lower than mycophenolate. Leflunomide's numbers were small but trended similarly. In the TNF inhibitor group, outcomes were comparable between infliximab and adalimumab, but not identical. Infliximab was linked to more anemia, hazard ratio of 1.81, thrombocytopenia, hazard ratio of 2.67, and pneumonia, with a hazard ratio of 1.47, but less skin soft tissue infection, hazard ratio of 0.39. No major mortality signal was seen with either biologic. These are not subtle differences. While methotrexate is often used as a default, this analysis underscores that mycophenolate in particular carries a substantially higher short-term risk burden, something to weigh when selecting therapy, especially in older or comorbid patients. TNF inhibitors, despite being third-line, appear to have a more stable adverse event profile in this dataset. This kind of large real-world safety signal is extremely valuable because RCTs in sarcoidosis are limited and often underpowered. In practice, I'd be much more cautious about escalating to mycophenolate without a compelling indication and would monitor hematologic and infectious complications aggressively. It may also strengthen the argument for considering TNF inhibitors earlier in certain severe cases. This is a reminder that how we treat sarcoidosis may be just as important as what we treat. Endobronchial valve therapy has become an established tool for carefully selected emphysema patients, but pneumothorax remains its Achilles heel. This nationwide Danish cohort, published in Respirology, provides valuable real-world data. Between 2017 and 2023, 228 patients underwent EBV treatment across all Danish centers. Pneumothorax occurred in 20.2% of patients. Median time to pneumothorax was 7 hours post-procedure, and the median chest drain duration was 13 days. Risk factors were clear. Upper lobe treatment carried a 6.3-fold increased risk compared to lower lobes. High target lobe volume increased risk with an odds ratio of 1.12 per 100 milliliters. High residual volume increased risk with an odds ratio of 1.11 per 10% predicted. Patients with pneumothorax also had a higher incidence of pneumonia with a relative risk of 4.5, empyema, and ICU admission with a relative risk of 9.89. Atelectasis at 2 hours post-procedure was more common among those who developed pneumothorax, suggesting rapid target collapse may play a pathophysiologic role. This reinforces the importance of procedural planning. Upper lobe targets and large volumes carry the highest risk. These patients need extended observation. A 24 to 48-hour watch may be prudent. Pneumothorax is not just a nuisance complication. It prolongs hospital stay, drives infection risk, and can blunt the functional gains from valve therapy. The accompanying editorial contextualizes the cohort and digs into why pneumothorax remains such a stubborn complication in EBV therapy. The authors highlight how the upper lobes, especially the left upper lobe, are consistently at highest risk, echoing prior series from Brock and Van Geffen showing similar lobe-specific vulnerability. Larger target lobes and lower diffusion capacity amplify the risk. They also bring an important nuance. Pneumothorax isn't just an early event. Management often involves chest tubes and sometimes valve removal, which reverses the lobar collapse and can negate therapeutic benefit. Reinsertion carries a recurrence risk reported as high as 43% in some series, though small numbers make this uncertain. Importantly, pneumothorax is a gateway event to other complications: prolonged hospitalization, pneumonia, empyema, and ICU admissions. In short, we need better predictive models and procedural strategies. Until then, patient selection and counseling are key. Every pre-procedure discussion should include a realistic pneumothorax risk estimate. Sometimes, preventing a complication isn't about new technology. It's about better conversations and smarter planning. Next, a highly anticipated RCT, the MABEL trial, published in the Lancet Respir Medicine, tackled a question we all face. Should we be prescribing low-dose oral morphine for chronic breathlessness? This was a multi-center, double-blind, placebo-controlled Phase 3 trial across 11 UK sites. It included 143 participants with MMRC equal to or more than 3 breathlessness from chronic cardiopulmonary disease. Patients received 5 to 10 milligrams twice daily of long-acting oral morphine or placebo for 56 days. Primary outcome: worst breathlessness score over the past 24 hours at day 28. Baseline breathlessness was around 6 out of 10 in both groups. Results? No difference at day 28. Mean worst breathlessness was 6.19 in the morphine arm versus 6.10 in the placebo. There was a modest improvement in cough score at day 56, difference minus 1.41, but not in overall breathlessness or quality of life. Physical activity increased slightly, about 9.5 minutes per day of moderate activity at day 28, but this was not significant after correction for multiple factors. Morphine was associated with more adverse events, 251 versus 162, and more serious adverse events, 15 versus 3. 13 patients discontinued the study drug for toxicity versus 2 on placebo. There were no treatment-related deaths. What does that mean? Despite physiologic rationale and lab-based evidence of opioid benefit on exertional dyspnea, this well-designed trial did not support routine use of long-acting morphine for moderate to severe chronic breathlessness in ambulant patients. That doesn't rule out carefully targeted use, but it should definitely temper enthusiasm for broad prescribing. This is a strong negative study. If you're using morphine for breathlessness, it needs to be for selected patients with close monitoring and realistic expectations. This next piece, published in Annals of Intensive Care, is a physiology-rich review, and one that goes straight to the heart of critical care practice. It asks, when we give large volumes of crystalloid, where does it actually go? The answer isn't in the vessels. After about 1.3 to 1.5 liters of crystalloid, the fast exchange interstitial compartment saturates. Further fluid rapidly accumulates in slow exchange spaces, the skin, gut wall, and lungs. These tissues have high compliance and act like overflow reservoirs. The heart itself, especially the subendocardium, is vulnerable to interstitial edema, with animal studies showing hypoxic lesions after massive infusion. Anesthesia and mechanical ventilation further compound the problem. They blunt diuresis by 85 to 90%, slow lymphatic drainage, and increase capillary filtration, accelerating peripheral edema. The review emphasizes how positive fluid balance isn't just a number. It represents real tissue edema in critical organs. In surgical patients, as little as an extra 2 liters can prolong GI recovery and increase infection risk. In ICU cohorts, large fluid accumulation correlates strongly with mortality. This review reinforces the importance of fluid stewardship. Crystalloids are not benign. Once the interstitial space is full, every liter goes where you least want it: lungs, gut, heart. In short, where the fluid goes is not a theoretical question. It's your patient's outcome. And that wraps up this week's edition of This Week in Pulmonary and Critical Care Medicine. We covered some impactful studies, from sarcoidosis treatment safety signals, to pneumothorax risk after valve therapy, to the role of morphine in chronic dyspnea, and a physiology review that reminds us why fluid stewardship matters. If you found this helpful, make sure to follow or subscribe so you don't miss future updates. I'll keep bringing you high-yield evidence summaries focused on what matters most at the bedside. If you want the links to the original papers, they're available in the episode notes. Until next time, stay curious, keep learning, and take good care of your patients.